Thank you, Professor O's invitation. Thank you, Chairman. Good afternoon, everyone. I'm very delighted to stand here and share the Chinese Society, Chinese Society of Clinical Oncology Guideline for colorectal cancer diagnosis and treatment with you. The CSCO guidelines take into account the disparate development of areas in China and the accessibility of medical resources, the value of tumor therapy, and therefore more practicable, readable, and accessible. The guidelines are revised every year. In version 2017, the treatment strategies are divided into basic and optional strategies, and in version 2018, they are changed to grade 1, 2, 3 as per recommendation. The grade 1 expert recommendation refers to good accessibility and explicit application, which are included in national health insurance and can achieve benefit for patients. Grade 2 expert recommendation refers to poor accessibility or low potency ratio. Grade 3 expert recommended as means of diagnosis and treatment being explored, although there is lacking evidence, but the panel reached a consensus. The primary contents include guidelines, principles of MDT, screening and genetics, diagnosis of imaging and pathology, principles of non-metastatic colon cancer treatment, metastatic colon cancer treatment, and rectal cancer treatment. Let's take the treatment principles of non-metastatic colon cancer as an example to look at the characteristics of CSCO guidelines. The treatment of non-metastatic colon cancer is divided into 3 paths: resectable, unresectable, and surveillance of colon cancer. For the treatment of resectable non-metastatic colon cancer, let's first look at the strategy for endoscopic therapy. For the patients with curable T1 colorectal cancer, if the submucosal invasion depth is less than 1 millimeter long, no lymphatic and vascular invasion, good differentiation, no tumor budding, tumor margin is greater than or equal to 1 millimeter, can be cured by endoscopic resection. The specific treatment strategies can be chosen according to the size of diameter and the type of adenoma and polyps. For example, if mucosal submucosal adenoma is greater than 20 millimeter, the expert prefer to recommend PEMR. The next choice is ESD. Further explanation is given in the description. For example, if margin can't be assessed, the endoscopy re-examined within 3 to 6 months. If margin is negative, the endoscopy re-examined within 1 year after endoscopic treatment. PMR may be required for the larger lesions, but PMR has a high local recurrence rate and monitoring needs to be strengthened. Next, let's look at the post-processing strategy for polypectomy by endoscopy. Patients with high-risk tumor features who underwent endoscopic resection need to advised to have colectomy. The poor prognostic factors include fragmented specimen, indeterminate or positive margin. Tumor cells can be seen from the margin is less than 1 millimeter or the margin of the electric knife. Unfavorable histological features, grade 3 or 4 differentiation, venous and lymphatic invasion. The treatment can be chosen according to the pathological stage and the prognosis. For example, in patients with PT1N0M0 pedunculated or sessile polyps with cancer infiltration, which means poor prognosis, experts prefer to recommend colectomy plus and block removal of the regional lymph nodes. In this description, good prognosis and poor prognosis are further explained. And all local resections or colectomy can be performed with conventional open surgery, laparoscopic and robotic surgery, depending on the local technology and the availability of equipment. The third is about the strategy for surgical therapy. The radical surgical resection is a complete mesocolic excision with en bloc removal of the regional lymph nodes. Colonic standing of distal colon improves one-stage surgery rates and decreases the risk of the permanent stoma and wound infection. For the patients with primary resectable non-metastatic colon cancer, if there is obstruction, perforation, hemorrhage, surgery, and colectomy plus or not en bloc removal of the renal lymph nodes is the first choice, and followed by endoscopic or interventional embolization for hemostasis, selective radical operation, or stand and two-stage radical surgery. In this description, radical surgical procedure and optional procedure is described. Laparoscopic surgery is not recommended for patients with bowel obstruction, and adequate irrigation and drainage should be chosen according to degree of the peritoneal contamination. The fourth is about adjuvant chemotherapy and common regimens. MOSAIC trial has proved patients with non-high-risk stage 2 don't benefit from FOLFOX. The high-risk factors of stage 2 patients include stage T4, poor differentiation grade 3 or 4 without MSI, high lymphatic venous or perineural invasion, obstruction and perforation, indeterminate or positive margin, insufficient safe distance of margin. Numbers of examined lymph nodes is less than 12. All stage 2 patients should make MMR protein testing. Stage 2 patients with MMR protein differentiation or MSI high may have better prognosis, can't benefit from adjuvant therapy with fluoramidine alone. For the patients with stage 1 disease, expert advised to observe. Stage 2 advised to observe or use 5FU monotherapy or observation or combined chemotherapy according to having low risk, general risk, and high risk factors. The stage 3 patients advised to combined chemotherapy. The stage 2 patients, the high risk factors as we have mentioned above. The low risk factors refers to MSI high or dMMR. The general risk factors means neither high risk nor low risk factors. It should be noted that in addition to clinical trials, the following drugs are not recommended: irinotecan, TAC4, TAS102, and all targeted drugs: bevacizumab, cetuximab, panitumumab, efanesoctocog, regorafenib, etc. In general, the total period of adjuvant chemotherapy is 6 months. Based on results of ideal trial, stage 3 patients with low risk features can be recommended as adjuvant therapy with Capiox for 3 months. Next, let's look at the treatment of unresectable non-metastatic colon cancer. The applicable patients are unresectable stage T4BM0. Depending on whether there are any symptoms or the primary lesion potentially can be resected, the main treatment means conversion therapy or palliative therapy, surgical therapy, interventional therapy, and concurrent chemoradiotherapy can be chosen. Based on the results of some clinical trials, CSCO guide points out local radiotherapy for some stage T4B patients, such as sigmoid colon with local invasion, can improve the remission rate and increase the probability of conversion resection. Some T4BM0 patients can't achieve the goal of radical cure even with combined visceral resection. It is recommended to refer to the following table for treatment. For example, the patients with primary lesion potentially unresectable with symptoms. Expert prefer to recommend local resection intervention embolization plus palliative chemotherapy. The next choice is local resection intervention embolization, endoscopic therapy, palliative chemotherapy. We must know patients with potential conversion should choose a chemotherapy regimen or a regimen combined of chemotherapy and targeted drugs with high response rate. And four-stage T4B patients with obstruction, endoscopic colonic standing, or bypass surgery can be used to relieve obstruction. Finally, let's look at the surveillance of colon cancer. For the patient with stage 1 disease, the follow-up frequency is every 6 months for 5 years. Stage 2 and 3 is every 3 months for 3 years, then every 6 months for a total of 5 years, once a year after 5 years. The contents include physical examination, especially anal-dictal examination, CA liver ultrasonography, chest, abdominal, pelvic CT once a year, and colonoscopy. And the patient with stage 4 metastatic tumor after arterial resection and destruction, the follow-up frequency is same as the stage 2 and 3. The contents include physical examination CA, CT with contrast every 6 to 12 months. The surveillance is performed to discover recurrence and metastasis that are potentially treated for cure. We know there is no high-level evidence or evidence-based medicine to support which strategy of follow-up is the best. Colonoscopy is recommended at approximately 1 year after resection or at 3 to 6 months post-resection if not performed preoperatively because of obstructing lesion. PET-CT is only recommended for clinical suspected recurrence, especially when conventional imaging is negative, such as an increasing CA level. Use of PET-CT for routine surveillance is not recommended. Okay, finally, if you have any feedback on guide, please send it to the email. Thank you for your attention.